convenient for the urologist. You know, you're in theatre, next, boom, MR fusion, boom. And so it's easier and it's comfortable. The patient's asleep. It's less cost because going into an MR gantry is expensive. And then if you want to, and you think this person might be suitable for a focal therapy, then you can do the random biopsies as well. You do the targeted and the random. So that's the advantage of that. I'll pass. So my selection of biopsy technique at the moment is as follows. If I've got a large lesion on MRI greater than 2 centimetres, what I'll do a cognitive MRI biopsy. I won't waste my time doing a fusion. I'll put the MRI up there. It's a big lesion, easy to hit. I won't miss it. If you've got a large missed lesion anteriorly, same thing, cognitive biopsy. If I've got an intermediate size, 0.5 centimetre to 2 cubic centimetre lesion, I'll use an MR ultrasound fusion technology. I use a fixed technique because I've done 7,000 transrectals, but I think if you're not that familiar with it, I think most of the people will end up doing a deformable one. If you've got an awkward intermediate-sized lesion in the anterior transitional large prostate, again, I do MR ultrasound fusion biopsies because I'm worried that if I'm just looking at the screen, I'm going to miss it. So big prostates in the front or in the middle of the transition zone. If I've got a small lesion, but I'm really worried about that lesion, 5 millimetres, maybe less than 10 millimetres, I would do an MR in gantry biopsy on that one. I'm just not sure if I get a negative biopsy whether it was really negative. Even if the pathologist says to me, you've got atrophy in that biopsy, it just worries me that I've missed it. Small lesion in the anterior part of the prostate, again, what I do is I do an MR ultrasound biopsy because the front of the prostate is really awkward to get to, and what I do there, I do a whole series of biopsies to be sure. I think this was another study we did where we're trying to work out whether MRI, prostate health index, which is using different PSAs, PCA3, which is an RNA secreted by the urine, or free to total PSA, was the best predictor of finding a cancer if you had had a previous negative biopsy. And way ahead of everything was MRI. We've just published that in, where did we publish? In British Journal. So planning. You know, there's lots of different treatments out there for prostate cancer. You can do open, laparoscopic, robotic prostatectomy, radioactive seed implant, IMRT radiotherapy, high-dose rate brachytherapy, active surveillance, and all this focal therapy. So with all those different things, and, you know, it's quite possible that the outcomes of surgery might actually be improved with MRI. So to help, I'll give you some examples of how I use the MRI to help me do things or choose therapy. Here, I've got a cancer right here. And as I'm going there, I go wider at that point surgically to actually clear that. If I don't go wider at that point, I get a positive surgical margin and that patient has to have radiotherapy. Here, midline tumour, there's a fascia which sits underneath here, which you can either go right next to prostate, higher chance of potency, or another millimetre away, lower chance of potency, but better chance of getting a negative margin. So here, where the cancer's right up against it, I go underneath the Devon-Villiers fascia so I don't get a positive margin. So knowing exactly where it is, I modify my surgical technique again. Now, this here is a big cancer at the base of the prostate eating into the seminal vesicle. There are different ways of dissecting the seminal vesicle, and if I know there's something there, then I'll go wider at the seminal vesicle, and there are different techniques there. What about if it's close to the neurovascular bundle? It's just there. There's the tumour here. Then I, again, might take some of that neurovascular bundle to make sure I get a negative margin. So it's like a roadmap. The most useful thing to predict extracapsular extension is not whether you can see it going outside the prostate, it's the extent of the broadness of the front against that area. So here you've got this long, broad front. That's going to unquestionably be extracapsular extension. You guys can't tell us whether you've got extracapsular extension. You can just say there's a high index of suspicion. Now this one, you know, when you've actually got frank neurovascular bundle involvement, then you have to actually dissect in a plane called an extrafascial plane to actually get a clear margin. Helps us again surgically. And this is the different fascial layers that we dissect in. We can either go real close, great for nerve sparing. You can go a little bit wider, you get a bit of neuropraxia, or you go right out here, in which case you're impotent. Anterior tumours. You know, if I've got a person like this with a big anterior tumour, not only will I go wide at surgery, but I'll tell that guy from experience he's probably going to have radiotherapy afterwards because you're probably going to get a positive margin at that area. Or you go radiotherapy up front. So it helps you choose. A large transition zone tumour, exactly the same. A broad anterior front, exactly the same. Extracapsular extension. All of these things will actually just give you an idea of how and what treatment to go at. For example, here, where at the apex you've got this massive lump of tumour at the apex, you cannot clear that surgically. It's impossible. Radiotherapy will underdose it. So what you're best to do in that is do high-dose rate brachytherapy to get a dose of radiation therapy sufficient to that area to actually clear it. So again, where the tumour is going to have an influence on which treatment and how you deliver it. I think Ronnie, you've done this, haven't you, Ronnie? Yep. Here's something. I don't know if Ronnie went into that. I wasn't here when he was giving the beginning of his talk. But the sphincter length can predict the likelihood of urinary control coming back. If your sphincter length is under 12 millimetres, and in other words, very short, then that person is at great risk of post-operative incontinence. And maybe that person shouldn't have surgery. He should be informed of that. Nodal Mets, you've seen some of the nodal Mets. MRI is great at sort of predicting the nodal Mets, and then you do a PSMA PET scan and just confirm that they are nodal Mets. Obviously, diffusion-weighted imaging seems to be important in this. Another node. So with planning surgery, I tend to use all the information I've got. It helps me with the degree of nerve sparing, where to go wide, the extent of node dissection, the likelihood of incontinence, biopsy understaging, and accurate preoperative counselling. So it really helps me enormously in my management. With radiotherapists, they say the same. They, you know, this is a highly sophisticated plan of a radiotherapist now. I think Gerald Fogarty's done this one, where he's got a patient where he wants to treat the nodes that he's worried about in the presacral area. He wants to treat the possible node here in the internal iliac, which was positive on MRI. So he actually doses that up to 68 Gray and actually tailors his radiotherapy to that actual node. But if you gave 68 Gray to that whole field, you'd actually burn your rectum and you have these terrible side effects. So you can actually dose it appropriately. It just makes sense. Active surveillance, yeah, you know, if you can use it for monitoring, then there's less biopsies. We've already almost finished that study. That's looking very promising. It tells you whether you're suitable for active surveillance. You know, you do all these biopsies, you've got a tiny low-grade tumour, you say you've got to have active surveillance, and then you do an MRI and you find you've got a big high-grade tumour at the front. You're totally unsuitable for active surveillance. It helps risk stratify as well. There's a long story about PSA or Gleason 6. I'm not going to go into that. So this is an example of MRI in the assessment for active surveillance. This is a typical person, 28 negative systemic cores, and yet 2 cores at the front thing finding the cancer in a person who they thought was suitable for active surveillance. Again, a 65-year-old man with a very low volume Gleason 6 in less than 1 core, but the whole anterior cancer was missed. So it helps you avoid that. This is one of my patients. It's an interesting one. This is a guy who he's going along on active surveillance. He, for some reason, didn't like the level of his PSA, so he gave himself a Zoladex injection. The PSA dropped, and then it went up again to 6. and then it fell on duodart because he had a bigger prostate and he had urinary symptoms, and then the PSA starting to rise on duodart. Not a good look. And so what we found in him was this tiny little lesion, but with a very low ADC value. So we're monitoring him with MRIs. There's no way you would have hit that with random biopsies. That was a Gleason 9 cancer, 5 millimetres in size, using MRI as your screening tool as part of your active surveillance. And this is the radical prostate, the biopsy pathology here, showing that Gleason 9 was in exactly the place we thought. And that was the radical prostatectomy synoptic graph, showing exactly the same. PSA recurrence, do we use MRI or PET? It's a whole different discussion. And we're about to start a trial comparing Combidex MRI using ultra-small particles of iron oxide with MRI and comparing that to PSMA PET. Most of us think that you need a combination of the two, and I think probably, in the interest of time, I won't go into that. But these are just some examples of PSA recurrences. Here's a MET in the bone. Adding diffusion-weighted imaging to MRI clearly helps you with bone mets. This is a person after these are just some examples, low dose rate brachytherapy. And so after radiation, it's a fantastic imaging modality to find out where the cancer is. You know, doing biopsies in these people is really hard. It's like concrete. Post high dose rate brachytherapy recurrence. This is a person with a PSA recurrence post radical prostatectomy and radiotherapy using a choline PET. And this was choline positive but MRI negative. We've gone away from choline and we're pretty well only using PSMA now. So this is old stuff. But this was an interesting study by a chap called Jelle Barents over in the Netherlands, and using Combidex MRI, and he was the one really who pioneered all this. He found that the lymph node areas that actually get involved with cancer of the prostate are nothing like what we irradiate or what we surgically treat. So as we understand this better and better, we're going to tailor our therapy more appropriately, and we're going to actually probably get higher cure rates. And that's probably why the cure rate's so low at the moment. And this is how it works. I don't know if you're familiar with this technology, but you inject the Combidex. It's a negative study. So here's the tumour in the prostate. So you inject the Combidex. It fills up the lymph node by being phagocytosed there, and it leaves a negative white area. So that white area, which didn't take it up, becomes the area here, which doesn't take it up, and that's a positive node. So just a meta-analysis back in 2006 in Lancet Oncology showed that ultra-small particles of iron oxidized with MRI lymphography was much more accurate than unenhanced MRI. So I think this will change. I'll pass on the choline and this. Oh, by the way, this is interesting. What does MRI pick up? What does MRI lymphography pick up? What does choline PET pick up? And what does PSMA pick up? So this shows that the size of the lymph gland metastases has a direct correlation with that. MRI is really only going to pick up 8 millimetres or more. Choline PET gets down to some of the 6 or 7 millimetres. PSMA PET, I can tell you from our study, gets down to 4 millimetres, and ultra small particles of iron oxide gets down to about 2 millimetres. So that'll all be for some future studies. Just pass on some of these. This is really sucking eggs in front of people who know how to suck. Positron emission. I think more interesting is, yeah, that this is just showing that PSMA PET is so much better than choline. I mean, choline's passé; it'll never be used again. So oligometastatic disease, just to finish off with, there's emerging evidence that if you have less than 5 secondaries and you treat them, you actually have a percentage of patients who go into complete remission. It's best assessed by a combination of MRI and PSMA PET. This is a typical example. This 75-year-old retired High Court judge I treated. Early 2008, PSA 16, then rose to 30. Biopsies Gleason 9. Bone scan, CT scan, MRI showed left inferior pubic ramus and right acetabulum met. On hormones for 2.5 years. PSA still less than 3.03. So he was given radiotherapy in the hope that if we gave it to the prostate, to the nodes and to the bone mets, he'd go into complete remission. He got 60 grey to his nodes and 84 grey to his prostate. And what's happened is he's actually 24 months after treatment, testosterone normal, PSA 0. So these are lots of people anecdotally like this, and there's currently 2 groups of people, one at the Peter Mac and ourselves, which are collecting oligometastatic data. And there's lots of details. Focal therapy has proven difficult because everybody thought that prostate cancer was just multifocal. And again, there's the question, which is the best treatment? There's no absolute proof of an index lesion. But if you can hit something with an MR-guided biopsy in the most aggressive part, then you can hit it with a therapy needle. 90%, but in 90%, only the indexed lesion is the one that actually kills you. So if the indexed lesion theory is right, then we have to shift from whole gland therapy, like we did about 20 years ago with breast cancer, to focal therapy. And the indexed lesion concept came out in the New England Journal of Medicine by Hashim Ahmed in 2009. It's been challenged by a couple of cases where low-grade cancers were the ultimate clone that killed the patient, but they're all anecdotes. So the focal therapy, what is focal therapy? Is it, do you treat this whole, 3/4 of the prostate, or do you just treat the lesion? These are the current energies that are being considered: freezing, cryoablation, radiofrequency ablation, ultrasound guided HIFU, MR guided HIFU, MR guided laser, photodynamic therapy, brachytherapy, and nanoknife. Nanoknife is irreversible electroporation. This is a typical case which would be good for it. And just remember that you've always got that 9mm of halo around it. If you start treating with lasers and treating just exactly what you see, you'll get a recurrence on the outside in a high proportion of people. So I regard our focal therapy as active surveillance plus. You still have to follow these people up because they're actually, unfortunately, going to be monitored. So there's lots of different energies. They're beautiful pictures of all these wonderful things. But I keep seeing all these laser patients who are being treated with focal therapy coming back with recurrences. This is what I've sort of taken up as my focal therapy program, and this is with an irreversible electroporation or nanoknife. Done about 80 cases now. This is a radical prostatectomy after one of these, and it shows perfect. There is no surviving cells inside the nanoknife area. We got 3 patients to agree in Melbourne to have their prostates out after a nanoknife. It's been quite hard to get it through ethics too. So we do this. We've done this collaboratively. We've published already on the safety of this in 34 patients. Mark Emberton and I published that and showing that 0 impotence, 0 incontinence, no major complications. It's a day procedure. So if you've got an anterior lesion, that's the lesion, what it looks like after a nanoknife. It just kills the whole thing off. Here you've got a lesion before therapy. That's the diffusion-weighted imaging. And this is afterwards, after the nanoknife. It just takes away that area. You get quite a bit of distortion, but it goes. You sometimes get cystic degeneration. Here was from Mark Emberton. He was using more HIFU to destroy this. He's a big believer in HIFU. The problem with HIFU is once it travels through the prostate, it loses its energy. The pitfalls of MRI Ronnie went through, the timing following that, the errors he went through, he taught me all this stuff. Actually, I should say, Daniel and Ronnie taught me this stuff. The perspectives to improve things, and now I feel like I'm a little bit inadequate talking to you, this audience. Sure, using an ADC map, perfusion fractions, ultra-high B values seem to be something that help you in some cases of prostatitis. It seems that everybody talks about ultra-high B values in some difficult cases. I've been working with a group over in Cleveland with MRI informatics, where we're looking at the collagen structure, trying to work out whether that can separate that negative predictive value to get it to 100%. And also we're using PET as well in combination with MRI. Now, this is some of the work I've been doing with Case Western, where we're looking at the collagen matrix in the ones where they say that's atrophy, that's cancer, and trying to work out if we can separate them. I'm just trying to look intelligent there. That's much more my style. Anyway, I think if you're, I stole this from somebody too, but if you're at the front of the pack, you tend to be, the view doesn't change. Thank you.